Good afternoon, everyone. My name is Angela Brand, and I'm with NAMI, California, and I'd like to welcome you to our workshop session, Ask the Doctor. This particular session will be focused on answering questions from you all about schizophrenia. I have with me today Dr. Luis Sandoval, who is working outpatient psychiatry with Kaiser Permanente. He's graciously taken some time this afternoon to spend with us to answer any questions and have some dialogue around this topic. We do have some questions that were pre-submitted through our polling feature on the Whova app, so we will start with those questions. However, I would suggest for those of you that are participating today, if we have any time left over, we will go into the live Q&A that we have through the chat box feature. So if you do have questions, please feel free to submit them either in the Zoom chat box or through the Whova conference app. So with that, we'll get started. I'm going to turn it over to Dr. Sandoval, and we'll go from there. Thank you, Dr. Sandoval.
Hi, thank you so much. Hi, everybody. I hope everybody's having a great day. Thank you for being here. First, I just want to thank Angela for all the hard work. I mean, obviously, it takes a lot to put this together, and there's so much going on, and trying to do everything virtually now. It's always quite a feat. So, Angela, thank you for putting this together and for hosting us. Like Angela said, I work here at Kaiser Permanente in Orange County in Southern California, and it's my pleasure to be here and answer questions. I've always enjoyed working with patients of all different mental health backgrounds and issues and diagnoses, but for whatever reason, psychosis, schizophrenia has always been one of my fortes. I've enjoyed working with this patient population. We did get some questions, so I'm going to go ahead and start with those. It's kind of nice to start with these questions because sometimes it'll answer questions that other people might already have. And then if you do have any questions on top of that or any other issues, this is perfectly the time to bring them up. So again, it's a pleasure to be here with you. As we know, with schizophrenia or psychosis, it's a very complex diagnosis, a complex condition, and it's different for different people. Some people will say, well, are you, if my loved one takes this, or if somebody takes this medication, is this the one that's going to help them? Which is the one? And there is, just as people as we're varied, we're different. The medications, the treatments, those can all be varied and different as well. So we really try to tailor the treatment to each individual person. Well, let's get to the questions. So one of the first questions is a really actually interesting one and important one because it does speak to the science of this. The question is, what is the role of in the course of the disease? Now, it's a broad question, and I guess I would have to ask the person, what do you mean by inflammation? But the way I can best explain that is we have to remember that this is a biological basis. What's going on with schizophrenia or psychosis is that in the substantia nigra of the brain, that area of the brain that controls dopamine, dopamine is being overexpressed, which means that the brain is producing too much dopamine or more than, or a higher level than the brain can tolerate or function with appropriately. So dopamine is an interesting chemical in the brain because if it goes down too low and we have too little dopamine, we end up with Parkinson's disease, right? So somebody who's being treated for Parkinson's disease, we have to give them L-Dopa or Sinemet or something that's going to increase the dopamine levels. In schizophrenia or psychosis, we do the opposite. So we realize that the dopamine level is elevated, so we want to decrease it. What's the role of inflammation in all this? Well, the way I see it is it would be more pertinent to the inflammation in the brain or the neurological system. And we don't really have a whole lot of scientific, shall we say, research study directly about brain inflammation, where we can say, gosh, if you're experiencing this, then we can use this kind of treatment. Usually we think systemic inflammation in the body will treat with steroids and things of that nature. But somebody who's experiencing psychosis, I would be very cautious of saying, well, I think there's inflammation, so we're going to treat you with steroids, because steroids can actually cause psychotic type symptoms. And so we want to be cautious with that. What I would usually say in terms of brain inflammation or neurological inflammation, we usually go more the natural route in terms of keeping a good diet, keeping good exercise, vitamins, over-the-counter natural herbs, things of that nature would speak more towards the neurological inflammation and addressing that in terms of can it help with somebody's symptoms of psychosis. Again, it's not guaranteed at this point. And I think that we need to do a little bit more study in that realm, but we haven't seen a direct correlation. I'm always happy to tell people, if you feel like something's going to help you, and as long as it's not going to cause you harm, try it out and see if that helps. So I don't know if I answered that question as far as the inflammation, but we don't have anything directly related to inflammation. So as far as giving you a straight, oh, inflammation, this is what it does for psychosis, we don't have that, but it is a good question to ask. The next question is, how common is trauma in a person diagnosed with schizophrenia in the past? Well, it's not necessarily a direct link, shall we say, that if somebody experiences trauma, they're going to end up with a diagnosis of schizophrenia or schizophrenic type symptoms. It really depends on what the trauma is. It's not a direct link, though, or directly causal. So it'd be more common, shall we say, for example, that if somebody experiences trauma, then I would expect them to have something like PTSD or an anxiety-based psychiatric condition associated with that. In terms of schizophrenia, however, it can result in trauma, because if somebody is psychotic, if they're not thinking clearly, if they go out and they start acting erratically in the community, if unfortunately they end up getting arrested because of it or placed on a 5150 or something along those lines, obviously that itself can be traumatic, and that can cause the person to maybe have exacerbation of their symptoms of psychosis, because now they're scared. Now there's this new element that's been introduced. But to answer that question, just because there's been trauma in somebody's past, that's not necessarily a direct link. Another thing to consider, which I believe is going to answer another question that's coming up on the list here, is, is this genetic, or what if there's a trigger? So in that case, if the person already say has a family history of psychosis or schizophrenia, and they already have, I would say, a neurologic trigger, there might already be a propensity where they could end up with psychosis. If there is a trauma, that might trigger it. If there isn't an inciting event where they went through something very traumatic, or something that they perceived as traumatic but nobody else did, a personal insult, embarrassed, we say, in high school or college, and really not being able to handle that, that itself can result in schizophrenia, shall we say, being developed or coming up, if there was already a genetic predisposition. But I can't say that just because somebody had a trauma in the past, then might end up with schizophrenia. I wouldn't link it that way per se. Can schizophrenia be dormant, or if there isn't a trigger, or is the onset of illness inevitable? So again, it pertains to what we're talking about. Is there a trigger? It can be dormant. Just because somebody has a family history of schizophrenia does not necessarily mean that they're going to have schizophrenia. It's just a greater propensity that we say, well, geez, if it's already in the family, if there is a history of it, then it's something you want to be aware of. If there is a trigger, it can come up. But sometimes a person will start to develop symptoms of schizophrenia without there necessarily being a trigger if there is a strong genetic link. So that is something to consider. But to answer this question, yeah, it can be dormant, and it doesn't necessarily have to be inevitable. Because let's say that somebody does have a gene or a family history of it, but they're never challenged, there's never any trauma, there's never a time where they experienced anything that was very horrific or psychiatrically activating, shall we say, they might never end up with schizophrenia or symptoms of it. So I wouldn't worry about it too much in that respect. I would just kind of keep an eye out and moderate that. And then, is it genetic, and if so, to what degree? It is genetic, probably about maybe 1% of as far as the degree. But if you think about that 1% in human nature, it's a pretty big number. So we usually say about 1% of the population has schizophrenia anyway. And if we think about that within, say, here where I live, it's Orange County, you're looking at a big number of people. You could have up to about 3 million people having schizophrenia at one time. So 1% of the population is a lot. It'd be 3 million people actually in the United States if we're calculating about 30. Well, actually, my number is off. I'm sorry. 3 million in Orange County based on the population size. But yeah, so it is genetic, about 1%. Let me see. One more question here. Why does my son think? Oh, this is a very, very important question. Why does my son think he has all these other ailments, but refuses to accept that he has schizophrenia? This is a very important topic, and in this case, this question it hits on a lot of notes. So one, already we're saying my son does have schizophrenia, so we're saying he already has a diagnosis of that. That's hard enough already as parents or as loved ones to accept that my loved one can have a diagnosis of schizophrenia. This really speaks to, how do I address it with them if they are not aware of it, or if they're not if they think they have other things. but they're not either willing to think that they have schizophrenia or they just don't see it. It's a question of what we call insight. And so this gets a little bit challenging. A person with schizophrenia doesn't have insight. It means that they don't recognize themselves that they are wrong. Now, this happens to all of us all the time. This is why if we have a good friend and they're able to tell us, man, you're acting really strange, or you can get very kind of bossy at times. And my initial reaction, no, I'm not bossy, right? And so that our reaction for anything. It can be you're bossy, you kind of get angry, you get irritable. And initially we kind of get defensive. We say, no, gosh, that's not me. The same thing can happen to somebody who has schizophrenia. They lack insight. It's on a different level though, because for us, I can say, gosh, okay, maybe I can recognize that I can be bossy certain times, but not all the time, or I can be, very take your pick jealous, or I can be angry, or I can be irritable, whatever it is. Um, I can take a moment to pause and say, wait a minute, are they right? Are they not right? What's going on? That's what we call insight. The fact that I to recognize what's going on. This is why therapy works for somebody who can do that and who's willing to work on things. But therapy usually is not very effective with somebody with schizophrenia, because if they go to therapy and they have no insight, without insight, there's no sense that there's something I could possibly change or something I could work on. Because why would I? Why would I change or work on something? I'm fine. I don't see that. And so this is where it gets very challenging, because somebody might recognize, I don't feel good. And you're saying, my son thinks he has all these other ailments, but he refuses to believe schizophrenia. So he might not see that he has other ailments. He might say, no, 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 I don't, or excuse me, he might see other ailments, but he's not going to recognize schizophrenia. He might say, I don't feel good. I'm just really anxious. And you're like, yeah, you are really anxious, but you're anxious because you believe that the cops are after you when they're not. And anybody who would believe that at the time is going to end up feeling anxious, right? Anybody who feels that they're being followed, or if you think the CIA is after you, or if you think that the neighbors are plotting against you or something along those lines, that's going to cause anxiety for anybody, really, right? But the question in this case is any of that real? Well, geez, if I break the law and I think the cops are after me, of course I'm going to be anxious. And if I really break the law, I have a reason to be anxious. But if I haven't done anything, but my brain's telling me that this is happening, this can be really hard to address, because a loved one, a friend, somebody on the outside is saying, this isn't really happening. And I want to convince you that this isn't happening. I want to tell you that this isn't happening. I want to show you the right way, because I want this anxiety to go down. I want all these other symptoms, irritability or anger that you might be experiencing because of this, to go down. But the person refuses to believe that they have schizophrenia. So why is that? It's because they have no insight. The important thing with this, though, is I would recommend in this case, a lot of people say, well, then what do I do? If they don't believe that, what do I do? How do I address these issues with my loved one? And I would say that the most important thing is to be honest. So not to tell them that they're not experiencing that, or that it's not real, because what we have to remember is that for them, in their mind, it is very real. They truly believe this is happening. They truly believe that they're being followed, or that there's a problem, or that they're in danger. This is very real for them. And that's the honesty I would use. I would say, listen, I know that for you, this is very real. I know that you truly believe that you're being followed, or you're getting messages, or that you're hearing voices, but I don't hear the same voices you hear. I know that you believe that that cop car that went by is probably looking for you. I don't see that. And so it's important to be honest and not say, oh, yeah, what you're experiencing is totally real, because I'm not going to go and call the police or do something along those lines either, because then they're going to say, okay, then help me. But to let them know this is really happening for you. It's not happening in my reality, but let me help you out. That might be a way to help them kind of recognize that there's something different, and I want to help you out. You're not necessarily alone. I want to help you out in what's happening. So sometimes that helps, but sometimes it can be very frustrating, and it might never get there, because the person might not recognize that there really is something going on with them. And that can be really hard. The next question is, can it cause high blood pressure psychosomatically? Sure. I mean, not schizophrenia directly per se, but I think that the high blood pressure might come from what we were discussing, from what comes with symptoms of schizophrenia. A person can be very anxious all the time, and they might not be always exhibiting that anxiety or talking about it. But if internally you're living in a different world, physiologically, the body's going to respond to that. And so they might be experiencing some higher levels of anxiety that we might not be aware about, that their body's going to be reacting to. And it can react with a higher blood pressure or even palpitations or something along those lines, which if anybody's ever had a panic attack or anxiety, they recognize that while my body's doing this, I'm having palpitations and sweating and whatnot, and I can't seem to control it. It might be a little bit similar with somebody who might be experiencing psychosis. If the psychosis is causing an increase in level of anxiety, causing a fight or flight response, because if you see somebody going by and you think that they're after you, or you're at the store and you think people are talking about you or making fun of you, that's going to cause some higher levels of anxiety. And I could see how that would cause the body to react physiologically and end up with high blood pressure in some people. It's not always the case, but it wouldn't be uncommon. It would be something to consider. Um, what age is appropriate to diagnose a child with schizophrenia? Great question, because a lot of times we think, gosh, schizophrenia is, you go downtown anywhere, big city, USA, and we see people unfortunately homeless or talking to themselves, and they usually appear to be older. But really for guys, I would say you range between 15 years old to 25 years old. And then for women, it's usually more 25 to 30 to 34, say 25 to 35. And these are just ranges. It can happen, really anywhere in between there. But for guys, it's not uncommon for it to happen early on, especially in the high school years and college years. That's where we see a lot of what we call the first breaks. For women, it's a little bit later in life. There are some rare cases, some instances of people developing these symptoms when they're older, say in their 40s or closer to 50. I was doing some research studies on that, and that's usually a little bit more associated with, say, head trauma or something along those lines, which can, cause damage to the brain and result in schizophrenic type symptoms. In those cases, if it's due to brain damage, it's not necessarily genetically linked, but it could just kind of be as a result of wherever the brain trauma might have occurred. Okay, so those are the questions that I have gotten that were emailed to me. I see that there is a chat room here and there's a list of questions that are coming in, and I'm going to read off of those now, if that's okay. Angela, is that okay?
Yeah, absolutely.
Great. And Angela, how are we doing on time? I'm not keeping track of that.
We are great on time.
Okay.
We've got about 40 minutes.
Okay, wonderful. Yeah, good. So let's see. There's a question from Judy, and she says, and so what I'm going to do with these questions, I'm sorry, Judy, you mentioned you wanted that private. So, okay. So we're going to keep that private. What I was going to do with these questions is just reread the questions, okay? And if you want them private, please let me know if you want them private. Let me see. So there's a question here. Is there any new research regarding schizophrenia and marijuana? Great question. That research is always going on. And you know what? That's been going on for a while, because I remember that even when I was in training. And so we're talking probably about 20 years ago. One of the things about marijuana is that sometimes we think, oh, it's an innocuous substance. It's no big deal. Gosh, even California says it's legal to use. The challenge with marijuana is that it's regulated. So it's not FDA regulated. We don't have anybody, shall we say, in a government type research agency saying, this is the correct dose, chemicals that we want to extract from marijuana. This is really what we want to use in terms of, it's best for maybe paranoid schizophrenia versus disorganized schizophrenia. We don't have that level of understanding of marijuana. What we do know, though, is unfortunately marijuana can actually induce psychosis. And so one of the things I always warn my patients about, especially that have any kind of psychotic type symptoms, is I tell them to stay away from marijuana for multiple reasons. A lot of people say, oh, doc, but it helps me sleep, or, oh, but it helps me for pain. Or I say, okay, it's buyer beware. Overall, the state allows you to have marijuana and sell it and whatnot. Okay. Studies have shown, though, and this is what I remember from when I was doing my training, is that people who use marijuana actually have a higher rate of potentially having symptoms of psychosis or schizophrenia. And this is especially true in the high school population. So I was mentioning that boys, starting around age 15 is where you start to worry. And this is what happens, so people can be as young as that, use marijuana, think, oh, no big deal. And then all of a sudden it's a psychoactive agent. So THC, which is a chemical that we look for, or say somebody gets pulled over and the police are doing a drug screen, we look for THC, right? And so that's the chemical that we say it's psychoactive, and it actually can induce schizophrenia. There was one study, and granted it was one study that I saw, might not be representative of all studies, but this one study said there was like a 400 or 500% greater chance of ending up with schizophrenia or psychosis with marijuana use. At the same time, what I would say is I would use more caution also, because I don't know what they're doing to marijuana nowadays. Now there's all these hybrids, and people go to dispensary and they say this one's good for headaches, this one is good for whatever it is that they think it's good for, and all of a sudden, how do they know that? I don't know how they know that. How do they come up with these different strains and these different ideas that marijuana is going to help in this way? It hasn't been studied. So the other thing I worry about is a lot of times people will lace marijuana, and maybe not at certain dispensaries, because they say, no, we want to keep up a good reputation. Of course, we want customers to come back. But if you don't know who you're getting it from, if you're getting it on the street or you're getting it from somebody else, for all you know, they could have laced it with methamphetamine, and that's a sure bet to end up with psychotic type symptoms. So with marijuana, I always say very, very cautious. I'll usually say no using any marijuana. That's my rule of thumb. Let me see here. Is there any medication effective at treating schizophrenia? And if not, what are effective treatments? So I guess the real question is, what do you mean by treating schizophrenia? Because there's no cure for schizophrenia. So medication can be effective at treating it, but keep in mind, our treatment plan right now is aimed at controlling it. So we don't have a cure. I can't tell you, gosh, if you take this, you're never going to have schizophrenia again. You're not going to have any hallucinations or anything along those lines. I can't guarantee that. So what I can tell you though is that if you take medication, the one that we use, so I mentioned before that schizophrenia or psychosis results from too much dopamine being produced in the substantia nigra of the brain. And so what's our treatment option, or our treatment modality, or our approach is, well, let's reduce the amount of dopamine that's being produced in that area of the brain. So antipsychotics, or another term for them is neuroleptics, the main goal is to reduce and control the level of dopamine that the brain is producing. And so that's the medication. It is effective. I've seen it work. To what extent, it really depends on the person, because now we need to talk about a few different things. So not every single medication is going to work well for everybody. And so sometimes to go through a trial of a few different ones. So let's say that you start with something like risperidol, and that worked okay, but then there were still a lot of voices, it wasn't well controlled, and you move over to Seroquel, and that one actually worked just perfect for this person, and they're feeling really good, and their voices are to a minimum. That's great. I say, perfect. That medication is the one that worked well for you. Obviously, risperidol didn't work well, but then all of a sudden, then I'm not going to tell them, you know what, risperidol doesn't work well, we're going to go with Seroquel. Because for all I know, for them, Seroquel might not work well, and we might end up needing the risperidol instead, and all of a sudden they find that that's so much better. So it's really person dependent as far as which medication is going to do the trick. Now, I mentioned that we normally control it, we don't cure it. So the goal when I tell people, hey, I'm going to treat you with medication, we're going to try different ones, this is the one that I've probably had the other patients seem to do best on, and that's fine, we'll start with that. And then they say, well, are these voices going to go away, or is the paranoia going to go away, or anything along those lines? And what I tell them is this, ideally, I would love for it to all just go away and for you to not have any more symptoms. That would be wonderful. And if that happens, great. I can't guarantee that. What usually happens, and what I hope for, is that whatever voices you're experiencing, or whatever ideas or delusions your brain might be producing for you, that if that's there, I hope that quiets down, and it's down to what I call the coffee shop conversation. So we can be sitting in a coffee shop, we can be at a table, drinking coffee, having a muffin, whatever it is you're doing at a coffee shop, reading a book, and you notice that we can sit there and talk, and we can listen to the conversation and focus on that. There's a whole lot going on around us, though. There's the cashier machine making noise as people are buying their coffee. There's coffee machines that are making a whole lot of noise. They're blending coffee beans or making the drinks. There's, the noise of the door, people going in and out. You can hear bells. In fact, there's other people around us talking. And usually that doesn't bother us because we can focus on our conversation. And that's pretty much what I can hope for, where if the medication works for you, all these voices, all these illusions, they just kind of go off to the side. And if you want to focus on them, you can look over, focus on them, and they're there. But they're really not bothering you. They're not, you can go through what you're doing, you can focus in the moment, and you're not going to be too worried about, whatever's going off on the side. That's ideal. If we can get to there, I'll take it. If we can get to even better than that, then of course, let's get rid of any of the symptoms altogether. That's perfect. But really, the idea is if we can quiet down the voices so they're not bothering you, because some of these voices can be very, very harsh. I mean, a lot of times it's very negative things that they're telling somebody. They're telling somebody to want to hurt themselves or things of that along those lines. And if you think about it, just to hear that once, it can be kind of harsh. But if you're going through life and you're hearing that over and over like a broken record, that can be really, really hard. I mean, that can be tough on the person. And why does somebody end up doing things like that or hurting other people if they're hearing this? Because after a while, it's almost hypnotizing or annoying, or you just want it to go away. You don't even know how because it's going on over and over. So if we can quiet that down, get that off to the side, it's not at the forefront or bothering us. We're already way ahead of the game. So that's the effective treatment of schizophrenia. The next question is, my son has been on the same medication for 8 years. He has resumed normal life, holds a part-time job. I think that's wonderful. I'm very happy about that. Somebody can be on medication, and it can be effective for many, many years. Some people take it, and after 2, 3 years, they say, gosh, it was doing so much better. I was feeling so well. And then after a few years, I don't know what happened. It just kind of stopped working. I'm back to, and that can happen. So then we sometimes have to switch medication out or see what's more effective. But if somebody's on for 8 years, that's very hopeful. And I appreciate that, and thank you for sharing that, because sometimes we wonder what's the best we can get to. And yeah, so for some people, they can take it for 8 years and all of a sudden it's back to normal, you know. And I'm glad that your son's been doing that for 8 years. That's wonderful. One of the big challenging parts for people is, my son's been taking it, or my daughter takes her medication. They do really well. Gosh, they can hold a job, they can hold a relationship, they can have what we call quote unquote a normal life. And all of a sudden they say, well, gosh, I'm feeling so good. Why do I need to take it anymore? And they stop taking it. That's probably one of the most frustrating things for everybody around, because everybody on the outside can see you do so much better when you're taking it. And I can appreciate that. For some people, that can be really frustrating. They're saying, why do I need to take this the rest of my life? I'm doing well. But again, we're only controlling the symptoms. We don't have a cure for it. So that can be really hard and frustrating. Something to consider there is just kind of supporting the person. One of the hardest parts too is that if somebody's been on medication and they stop it, and all of a sudden they want to get back on it, sometimes the same dose is not effective enough. Sometimes all of a sudden you need a higher dose. And you're like, well, why is that? That's just kind of how the brain works. It takes a hit every time. So if I stop my medication and the symptoms resume, all of a sudden I just took another hit. I took another mental hit, and now I'm going to need a higher dose sometimes to help get me back in control of the symptoms. But good for you. I'm glad that your son's been able to do that. Okay, so great question here. Can meth use cause long-term schizophrenia, and can someone recover from using meth? So absolutely. Meth is one of the most challenging drugs. Well, let's back up a little bit. What is methamphetamine, right? It's an amphetamine-based medication, but where does it come from? Because some people say, well, doc, with amphetamine or meth, my friend, they've been on Adderall or Ritalin, and isn't that an amphetamine-based medication for ADHD? So what's wrong with it? Well, there's a big difference between amphetamine and methamphetamine. And if you look at organic chemistry, adding a meth group to a chemical can change it significantly and can change what it does significantly. The other thing to consider is that ADHD medication, which are amphetamine-based, are produced in a laboratory by, for pharmaceutical companies. Methamphetamine is not legal. It's produced in somebody's garage, somebody's RV, watching any shows on methamphetamine production, or somewhere out where people, the substances used to make methamphetamine are pretty much like gasoline, turpentine. This is just pretty much a poison that's been concocted. And I don't know who's cooking it. I don't know who's making it. I don't know how do they even know if they're doing it right. And so one of these things is you're ingesting a poison into your system. So keep that in mind. Methamphetamine is really just a dirty, dirty drug. And the question is, can it cause long-term schizophrenia? Actually, yes, it can. For some people, if they already have the propensity for it or have a gene for it or anything, it can be a trigger where a one-time use of methamphetamine can actually induce symptoms of schizophrenia. And that can be really hard for family members. I had a patient that actually happened to one time. He used methamphetamine, maybe just a couple times. I don't think it was just a one-time use, but he was, shall we say, finishing high school, starting junior college, used methamphetamine, and he really got to the point where his best level of functioning was just kind of playing video games all day at home and not causing disruption. Because if he didn't take his medication, he started kind of really getting paranoid and disruptive. So with medication, the brain is very slow to heal. And so the medication is very subtle. You need to take it over time. The brain is very quick to get damaged. Just a few hits of methamphetamine or something along those lines can damage the brain right away. Frustrating for families because they say, gosh, I just kind of want, they were fine 2 weeks ago. Now I just want to get them back. Can't you just give them something and tomorrow they'll be better? No, if there was already damage done by the methamphetamine, because who knows how it was cooked, how pure it was, or how it came about. If there was already damage done to the brain, we got to let the brain heal and we got to give it time. Unfortunately, there was a lot of stigma for the family that their son, their loved one, was taking medication to treat their symptoms. There was a lot of idea and a lot of hesitation and mistrust, really, of the medical system. And what happened to him, unfortunately, was that he ended up committing suicide because the family discouraged him from taking medication. They thought that the medication was making him worse, or that it was actually preventing him from feeling better. And for as much as he tried to explain to them, this is very subtle, it takes time, they said, no, we're not going to give him any more medication. We want we want him to get better, but we don't want him to have taken medication in order to get better. And so that's where what happened was they stopped the medication. He got back into more intense symptoms, and he went and he ended up. The story was that he jumped off of a parking garage. He used to work at a parking garage, and he's ended up back there. I don't know if he was using methamphetamine again or drinking alcohol, and he lost his balance or whatnot. Either way, they ruled it a suicide. Again, can methamphetamine really cause a lot of problems? Yeah, it can. It can be hard. Can somebody recover? They can. Might just take a little bit of time. Okay, so we also want to be patient to let the brain heal. The next question is there a different approach with assisting an individual during a manic psychosis versus a person with schizophrenia? Great question. So manic psychosis, we're talking about bipolar disorder, and really if somebody's in mania, one of the they can actually have a psychosis. So they're going through a manic episode. They might feel grandiose. They might feel like they're getting messages from God, or they have a mission and they're an angel. And, I've seen this happen to some of my bipolar patients, especially when they don't take their medication. And so we say that they get into a psychotic phase, but it's because they're in a manic phase, and it's a manic psychosis versus a person with schizophrenia. The approach can be, it's a great question. What's the approach to each individual person? I think the approach might be different, because even within schizophrenia, the approach is different depending on the person and who they are and what they're going to react to. As far as the medication treatment, though, we treat psychosis the same. We always use antipsychotics. So even somebody who's got bipolar disorder, yes, we are going to use mood stabilizers, and they can be either like lithium, which is a pure mood stabilizer, or they can be something like a anti-epileptic medication like Depakote or Topamax, which serves both to prevent seizures and also to treat bipolar disorder. So those are going to be, of course, a staple to treat bipolar disorder. But when there is psychosis involved, somebody with bipolar disorder, we also give them an antipsychotic because we got to treat those symptoms. It also speaks to, I would add to this question, if somebody's having a manic psychosis from bipolar disorder, and a person is just having pure psychosis from just pure schizophrenia, and let's say somebody is having psychosis because of methamphetamine, it's the same treatment. We still treat with antipsychotics because we're treating those symptoms. So that's a really good question. I mean, the approach is the same as far as medication. The approach of how we speak to the person, how we let them know what's going on, that might be different, in that we might need to tailor to the person individually. The next question is, what is the latest status of medical science ability to objectively diagnose a mental illness, say through blood sample, tissue sample, brain scan, or other biological marker? Really, we don't have that. It's really symptomatological, meaning that we go based on your symptoms. So If somebody is schizophrenic, I don't look at their dopamine levels per se, but no different than if somebody is has Parkinson's disease. You don't necessarily look at their dopamine levels. You treat them based on the symptoms that they're having. So based on the symptomatology is how we decide what it is that we're going to prescribe and how we increase the dose or decrease the dose. Reason being too is because sometimes why is it that some people react? Some people can be very, very sensitive to certain medications, and other people might need higher doses. And even if you look at the levels of, say, serotonin or levels of dopamine, they might have the same levels, but they might need different levels of dose or different medication doses. And so it's very person dependent that way. But to answer your question simply, not necessarily. Now, you're going to hear different places that say, oh, yeah, sure, if we take a salivary sample, we look at your saliva, your DNA, we're going to run it through, or we're going to do all these brain scans, and that's going to help us really figure out what's going on with you. If that were the case, and if we could truly do that, then by all means, Kaiser would already have these tests in place and we'd be running them. All the university systems would be having it in place. Medical systems across the board would put this in place because obviously we want to help people and we want to make sure that if I can gain insight into a better way to administer medication, I'm going to want that. We love doing lab work and we love looking at numbers, and the more we can have that, the better. But that doesn't exist just yet. The way I would look at this is look at what's happening or what people are doing, what medical centers are doing across the board. And that would be an idea as to really what markers do we have in the medical community that we use. So let me see here. This one says, okay. So I'm going to go back to the question that was there before. This is where somebody's son was diagnosed with schizoaffective disorder 18 years ago. They're 38 years old. Then 7 years ago, started using methamphetamine. Can methamphetamine really interfere with their recovery? And you think it's causing schizophrenia? So yeah, I mean, one of the challenges here, let's say somebody's diagnosed with schizophrenia or schizoaffective disorder, and their brain, we already know, has a propensity for psychosis or something along those lines. And then all of a sudden we introduce methamphetamine. Well, this is going to be a big challenge because, like I was saying before, methamphetamine can be very, very damaging. And all of a sudden now, how am I going to know how effective my treatment is? Because I can give you medication at this point, but as I'm giving you medication, you're working against my medication. You're working against trying to let the brain heal. And this is true not just for methamphetamine. This is actually true, say, for somebody who introduces alcohol and is drinking a lot of alcohol. I tell my patients, I prescribe medication, I say, hey, you know what? While you're on this, no alcohol. And boy, that's really hard for some of them, especially if they're just kind of social drinkers or things along those lines. And they're like, doc, but I just have a little bit of anxiety or a little bit of depression, like no alcohol. And really the question comes down to how married are you to your alcohol? Because what's really happening, I'm giving you medication to help the brain think clearly. And what does alcohol do? We all know that if you drink too much alcohol, you're not going to be thinking clearly. The brain's not going to be helping you out. You definitely can't drive. So it's really interfering with that healing process. And like I said, the healing is very slow and subtle. And so if somebody introduces, say, methamphetamine, and they already suffer from schizophrenia, that can make it just that much worse. And it can really prolong the healing of the brain. Not to say that if they don't recognize that, hey, I'm going to stop the methamphetamine and get on medication and treat my schizophrenia or schizoaffective disorder or anything along those lines, that's not to say that they can't get well controlled. The hard part is that once somebody starts using methamphetamine or an addictive substance like that, boy, that can make it really challenging to get any kind of healing down the road. So I would try more than anything else to see if the person is willing to stop using drugs and to really focus on the healing process, okay, as far as their medication. Let me see here. So the next question is, does Kaiser offer a specific cognitive therapy for people with schizophrenic diagnosis? By cognitive therapy, it sounds like cognitive behavioral therapy or CBT. While a person has active symptoms of schizophrenia or psychosis, and if they don't have insight, if they don't recognize that this is going on, it can be really hard to get any cognitive therapy to be productive or to actually function or work. Because again, that moment of insight, that level of insight is what's really needed for therapy. If I'm going to go to therapy, the first thing I sit down, the therapist is going to say, well, what's your goal of coming to therapy? Why do you want to come here? You know, and if I'm, let's say I want to work on my relationship with my girlfriend or something. Okay, well, I want to work on this. We've been arguing a lot. She says that I am like this, but I believe this. And you can start challenging those thoughts. And as long as you can challenge those thoughts, that's what we really call insight. The challenging part with schizophrenia, again, is the lack of insight. You see that because you can't challenge a thought. So if somebody comes in for therapy and they say, well, what's your goal for therapy? And then they say, I need to stop following me. And you say, okay, well, do you really think the cops are following you? Well, yeah. Well, did you do something? Did you break the law? No, they just keep bugging me and they keep following me. Okay, well, let's try to see this a different way. No, now why don't you believe me? Wait, are you in on with them? Are you going to call the cops? See what I mean? So there's no insight. There's no sense of, gee, maybe there's something wrong. You know, maybe I'm not thinking clearly. Maybe if we can get to that point, if somebody says schizophrenic and they medication and they have that insight where they recognize, yeah, now that I'm on medication, I'm feeling a lot better. I was thinking some weird things. Then all of a sudden we can do therapy, but it's more the life therapy. But there is no therapy per se that'll say, gosh, this person's not thinking clearly. I think they have schizophrenia. Let's put them in therapy and that's going to bring them back. That pretty much just doesn't exist, which is hard. It's hard because I understand a lot of families tell me, you know, would therapy help? Not really, not if there's no insight. That's the key. So the next question is, will standard of care include a brain scan to properly diagnose brain disease? Our son shows signs of schizophrenia, but has only gotten a bipolar diagnosis. He went missing for 6 years and returned to us a few months ago, and we can't figure out what to do to get him, especially to help him, excuse me, especially now with COVID-19. Great question. A brain scan, so it's a great question because a lot of times people think, obviously there's something wrong with the brain. If you do a brain scan, you can see the area of the brain that's wrong and then you can treat it. The interesting thing about neurology is that it's kind of like Star Trek, the last great frontier. You know, space is our great frontier in those series. The brain is the neurological system is kind of our last great frontier. If you notice, if somebody has an unfortunate where say that they break their back, they break their spine, and all of a sudden they're paralyzed from the waist down. We don't have a way to bring that back. Our neurological advances are not that sophisticated to say, gosh, if we tweak the nervous system this way, then all of a sudden we can get it back to working 100%. So it's kind of the same thing. You can do a brain scan, and there are some clinics that'll do brain scans for thousands of dollars, and they have libraries of brain scans. But again, you'll notice that some of these clinics exist, but not across the board. So there might be one particular clinic who's doing a brain scan, but if you look at all the major medical centers across the country, is everybody doing brain scans? Probably not, because they're not going to tell me a whole lot aside from, let's say that all of a sudden, unfortunately, you have a tumor, or you have atrophy of the brain, or you ended up with a stroke. Well, that's going to help me out to see that, yes, there is a source or a reason why your brain might not be functioning properly. And based on the area of the brain that's damaged, I can see that, that these are symptoms to be expected. In the case of mental health, though, it's very frustrating because if we do a brain scan, some areas might light up, some areas might not. But this is at the micro chemical level where it's happening, where it's not going to tell me a whole lot. The main thing is, your son shows signs of schizophrenia, has only gotten a bipolar diagnosis. One of the things about that, though, is I would look at what kind of medications is he on. While he has a bipolar diagnosis, is part of his treatment also a neuroleptic antipsychotic, which normally it would be something like a Haldol, a Geodon, and a Abilify, what else is there? Latuda, something along those lines are they taking something along those lines? Then you can say, well, regardless of what the diagnosis is, this medication, if he is having schizophrenia, this medication should be addressing that. And how well is he progressing? Now, if he went missing for 6 years, I'm very sorry to hear that, and he returned, I would wonder, did he do any drugs during those 6 years? Was there anything damaging to the brain during those 6 years? And that might be something that we might never know. The person might not even remember. They might say, oh, I took a pill one time and somebody gave it to me and I didn't know what it was. I just took it because I thought I'd feel better or get a high or something. I don't know. But again, I would say, even with a diagnosis of bipolar, I would inquire as to see, well, what medication is he on? What treatment is he getting? And what are the street schizophrenia anyway? And that'll give you a better idea, is that being covered? There's another question of somebody has a 30-year-old son. Let me see here. somebody has a son who's getting treated, but the symptoms apparently are severe and resistant to treatment. Ambien knocks the voices back, and you wish that the doctor would allow off-label use, and you I see, you tried different medications, different times, in different combinations, including Clozaril. So interesting with Ambien, by knocks voices back, I'm assuming that you're saying that it decreases the voices. One thing that I would say with Ambien, it's interesting that it would decrease the voices. So Ambien is a sleep aid. It's a hallucinogenic, as we call it, or I'm sorry, not hallucinogenic, a hypnotic. It helps people go to sleep. And one of the challenges that we've had with Ambien, though, is that it can actually cause hallucinations or people to be forgetful or people to sleepwalk. So we actually try to avoid using it a lot of times, especially if somebody is having altered mental states. We try to keep away from anything that might cause even more of that. If in your son in particular, it seems to be helpful, that would be interesting, because as you notice, you said you wish that they would allow off-label use, but I wouldn't be able to speak to that. It might just be this particular case where that's happening, but as a whole, I don't know that anybody would actually prescribe Ambien for this, because already we know that it can cause an altered mental state. And if somebody's experiencing that, we wouldn't want to make it worse. It would be interesting. I mean, I would just say, talk to your doctor. If this is your experience, I would let them know what you're experiencing and see if they're willing to maybe try it. But it would be very different from the standard of care, though. But good point. So can I comment on the cross between autism spectrum disorder and schizophrenia? It seems uncommon, but I've a few people having both diagnoses. My son is one of them. It's very, very interesting to consider. Is autism spectrum disorder and schizophrenia, are they linked? One of the challenges is, what is the criteria that we're using to diagnose either one, especially in children, as they grow up? Because sometimes we give a diagnosis of autism because the person shall we say, socially has not developed, or the verbal has not developed. They might need speech therapy. Emotionally, they might not be able to interact appropriately, right? These are some of the basic symptoms of autism. One of the questions I would have, though, is why did these symptoms come about? Because we can give it the diagnosis of autism, but was there, and I don't know about your case in particular, but one thing we would have to ask is, how was the birth? Was there any problems where there was a compromise of oxygen? Were there any problems where during the birth, would the child get stuck? Were there any issues there? That's one thing I would start with, because sometimes we get children who have cerebral palsy and they end up with a list of diagnoses: autism, schizophrenia, ADHD, all at the same time. And really, at that point, what we've been treating as behaviors. We don't normally see, say, autism, and then we think, oh, this person is going to be schizophrenic. It's not a direct link, but it can happen that if somebody is diagnosed with autism, can they have schizophrenic type symptoms on top of that? Sure. I got to look at their whole history, though. I got to look at, were they born with autism without any cause or anything that we can think of, which is most commonly, we don't know where autism comes from. But did they develop symptoms of autism? And at the same time, did they have a family history of schizophrenia? Potentially, because we know that in autism, something's just not clicking in the brain and we wanted to get it to click. And if there's already a family history or a propensity in that particular person for schizophrenia or psychosis, then we have to look at, could the autism or whatever is going on in the brain at that point have triggered symptoms of schizophrenia as well? And that's possible. I would look at, the future. Is this person also going to be diagnosed with ADHD? What's their attention? I don't know what the age group of the person is, but it would be very person dependent. We would have to look at, um, again, it's more of the history. How were they born? Why are these two symptoms there? I have heard of it, but then at the end of the day, it's what is the treatment that we're going to use? What is it that how are we going to help this person out? And it's really symptomatological. Let's take care of the symptoms. The next question is, yeah, sure. So when there's a lack of insight, using the proper term because it's hard to pronounce, it's anosognosia. Does it usually persist over the course of illness, or does it typically decline over time? Great question. So yes, we've been talking about, is there any in the person, are they aware of what's going on? And that would be a great key for maybe therapy and getting the person to take their medications and things along those lines. It's very person dependent, and it's also experience dependent, because sometimes I've seen people have an experience where all of a sudden they say, "Hey, wait a minute, this isn't real, or is it? Now I get it," and something kind of clicks, and there's no way to predict it, or to stage an experience where this is going to happen. It just kind of happens for some people, where they say, you know what, I'm going to trust you now, because I don't think you would put me in a dangerous situation, and you're telling me it's safe to come here or go there. Okay, then I'm going to start trusting you. Sometimes somebody might have an experience like that, where all of a sudden they say, I don't see it, but I'm going to trust what you see. And that can be key. Now, is it possible for the lack of insight to improve time? It's very person dependent. I can't say. Usually, I would dare say that I would err on the side that it's pretty hard to get somebody to really gain insight if they're adamant that they are right, and that what they are seeing is the truth. Then it can be a little bit challenging for them to gain some insight there. But I would keep working on it. And honestly, I think the best way I've seen it happen, or hope for improvement, is when we let the person know that we see a different reality, but that we respect, that we see their reality, we see and believe that what they're experiencing is true. Absolutely, they're experiencing their world is 100% true, but we see it differently. That's usually the best way to start to helping somebody gain some insight. Um, so the next question is, so no brain scan will be used ever? I don't know that no brain scan will be used ever. That's a great question. I hope that there is. I say the more diagnostics we can get, the better, because then that'll let me know, hopefully much better, what medication to give, and what we're treating, even how to approach therapy. Because what good is it for us to just kind of talk to people and say, oh, you have depression, and this is what you're going to be like, or you have anxiety and this is what you're going to. I think the more we can use, the more brain scans, the better. I hope that there's a brain scan. It would just be more a matter of, I think we would have to have a different technology than we have now to scan the brain. Because what we really have right now, it would be more what we call the PET scans. What we have right now in terms of brain scans, like CT scans and MRI scans, they're really good at letting us see and anatomy of the brain vessels, the arteries, the veins. They let us see the spaces within the brain where the cerebral spinal fluid is. We can see the different size of the brain mass, and we can even see when the brain mass starts to deteriorate and it starts to get smaller. And that happens to all of us as we age. We see, the brain mass get smaller. So we can really get a good physical representation and make interpretations based on that. So if I look at somebody's brain scan and say, unfortunately they had a stroke, and I can see on the brain scan brain tissue died, or where the blood went, or exactly what happened, it gives me an idea of what's happening in the anatomy of the brain. That area of the brain should do this, so this is what I expect to happen otherwise. But when it comes to mental health, again, this is more at the biochemical level. So I think if we could refine more the PET scans, and those are the ones that you see more where different colors light up, right? So, oh, this part of the brain, this lit up in the ventral tegmental area lit up, or the parietal lobe lit up. We'd have to get much more refined than just the area. We'd have to get down to this nerve lit up in this area, or this particular group of nerves lit up. And then we have a better idea. Right now, it's just much more generalized, and it's not enough to tell us where we're at. Now, granted, technology is always advancing, so I am very hopeful that eventually that will happen. It's just not there yet. What are some subtle warning signs before relapse? Great question. Actually, really, really good question, because this we should actually talk about what are some subtle warning signs before even our first break. So, which would be kind of the same. Um, let's say you have a teenage son, and we'll go with the boys because the men, like I said, we usually develop symptoms earlier if we're going to develop them 15, 16, 17 years old. Usually, some of the first signs are isolation. The person's in the room, they're kind of by themselves. They don't mind playing video games all day. They kind of don't come out. They're on the computer all day. They're on the internet all day. It's kind of like they're in their own world all of a sudden, and they stay in one place. Lack of socialization. They stop kind of talking. Let's say, let's say that they've been living with it and they've been in treatment, and now they come out and they want to talk to you. Normally, you guys have breakfast together, a cup of coffee, whatever it is, and then all of a sudden that kind of stops little by little. The person doesn't want to come out more. They start having different ideas. They might ask you a question where you're like, "Huh, that was weird. Why did they ask that? That wasn't part of the conversation." Little things like that, where you kind of start getting hints that something's a little bit off. Sometimes we want to ignore it because we don't want to assume that, oh, here it comes. We don't want to jump to that conclusion. But it's something to look out for. This is where we got to ask, well, if somebody's been on medication, are you still taking your medication? If this is brand new, something to keep an eye on. I'm gonna take a little drink here. Sorry, my throat's a little dry. Okay. The next question is, so this is a case where there's schizophrenia in the family, and it happens to be in the father-in-law. What are the odds that our children suffering from it? Also, what is the age for a female that I should start looking for signs? So, here's something to consider. If it's in the grandfather or husband side of the family, things of that nature, how much would I worry? I wouldn't worry too terribly much because there's a lot of protective factors. To answer your question about the female, we talked about this before, usually around 25 years old to 35 for females, but you can start looking as early as 20 years old for any kind of symptoms. But here's something to consider. A very important protective factor is education. So we start to worry about, oh my gosh, what if this develops? Now, that's not always the case because I have some patients who went through high school and now in college, and they ended up developing psychosis, and I'm treating them, and they're doing well. But education can be very, very protective, keeping the mind active, recognizing that it exists. And in fact, in this case, even talking to your daughter or your son, or whoever it is, if you already know that there's a family history of it, let them know what this is, because you don't want to keep it quiet and say, well, I don't want to mention it because I don't want to bring up any ideas. And then all of a sudden it happens and the person's taken aback. It's probably better to say, this kind of runs in the family, so it's good to keep an eye out on it, so that if these symptoms do develop, then the person has much better insight, as we were saying, and you can say, hey, remember what we were talking about? I think this could be happening. Let's figure this out for you. Let's try to see if we can get you help. So that's something to consider there. What are the odds? It really just depends on, are there triggers? Are there, is the person even gonna, do they already have a propensity or not? Because just because somebody in the family has it doesn't mean it's necessarily going to be passed on. It's something to consider though. Okay, let's see here.
Dr. Sandoval, this is Angela. I just wanted to pop in real quick with a time check. We have about 5 minutes. So, maybe time for, 1 or 2 more questions.
Okay, well, we have a lot of questions here. Thank you so much. Give me 1 second here. Let me scan through the questions for a minute and see if there's a tying theme in all these. There's a lot of them here, so give me 1 second. Okay. Mm-hmm. 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 Okay, great question. So what in terms of treatment, there's all different medications out there. And one of the questions is, what about with clozaril or clozapine? Is there weight gain with it? Is there something else as effective as this medication? It's very person dependent. For some people, unfortunately, they really need to take a lot of medications. And clozapine is kind of our last ditch effort here in the United States because of the side effects that can occur with it and our lab work that we need to keep tracking. But it's really person dependent. Some people go through their whole lives and they do better, they do well without it. Somebody who has taken it, that might be what they need. So it's something to consider. Is there any medication without the weight gain? So weight gain is interesting because it can happen differently for different people. So some people might take certain medications and they might have the weight gain. Other people might take the exact same medication and not have the weight gain. And as far as how effective it is, your daughter might be able to take a different medication that's just as effective without the weight gain. But I couldn't tell you which one. It would be kind of a trial and error. It would be like, hey, let's try this one or let's try a different one. There's another question that says, I see people whose children are very angry and they have schizophrenia. What is the reason for their anger? So, and the children are very angry. So I guess I would ask, what's the age range of the children? Are they older? Are they younger? But the anger might come from the frustration, well, for different reasons. One, it could be what's their schizophrenia? What are they hearing? Are they hearing negative thoughts all the time? Is this something that's plaguing them all the time? Are they constantly being berated and being told to hurt themselves, or that they're no good, or that they should hurt somebody else, or that nobody loves them? If you're hearing that all the time, you're going to get sad, depressed, and probably angry. The other reason for anger might be, people don't believe me. And I keep telling them that I'm hearing these things and nobody believes me. I feel really alone, in this. I feel like I'm in my own world and nobody understands it, which is unfortunately true for a lot of people because the world. But again, if nobody extends that sense of, hey, I think you're going through something and I'm going through it, I don't see that, they might end up with a lot of anger and resentment. It would be really more interesting to talk to the person individually and see where they're at and ask them why they're angry. But that could be some of the reasons. And the last question is, are there any DNA testing useful for prescribing? Not at this time. Excuse me, not at this time, because it's different for different people. So again, it goes back to, some medications work well with some people and they don't experience side effects from it, and other people do. But we don't have a test where I would say, oh yeah, definitely, let's get this test and I'm going to know what to prescribe for you. It just doesn't exist right now. I hope that helps.
All right. Well, thank you so much. We had so many questions. I will say I'm really excited that we got to do this session live versus the pre-recorded option
No, this is great.
talked about, because I feel that we got in so many questions and really got to make a dent. And I apologize for those of you whose questions we didn't get to. That's not enough time and always more information. So again, thank you to everyone who joined us here today. We will have a recording of this session available to those of you after the conference. If you wanted to share this, any of the information actually from our conference will be available for folks after the close today. So with that, I just want to say thank you so much to you all for taking time to join us today, answering all of the questions that came up and sharing your expertise and your perspective with all of our folks here. And with that, I just want to say thank you to everyone for joining us. I hope you stay well and healthy, and we will see you next time. Thank you.